Next up, we will hear from those who are on the front lines of the effort to combat the opioid epidemic. We will explore local and national strategies, examine how barriers to treatment and recovery can be addressed, and ask what can be done to combat the stigma associated with addiction. So please welcome on stage Kenneth Stoller, Director of the Johns Hopkins Broadway Center for Addiction, Gary Mendell, founder and CEO of Shatterproof. Shatterproof was founded after Gary Mendell lost his son Brian to addiction in 2011. Nora Volkoff, Director of the National Institute on Drug Abuse, and Michael Frazier, Executive Director of the Association of State and Territorial Health Officials. Joining them on stage is the Hill's healthcare reporter, Rachel Rubine, and she will be leading this conversation. Rachel?
Hi, good morning. Thanks everyone for coming out. Special thanks to our panelists as well. No secret that the country is grappling with a horrible opioid epidemic, and we've seen the death rate from heroin prescription painkillers quadruple since 1999. So I wanted to kick it off talking a little bit about the federal government response. And a question for you, Michael. President Trump has said that his administration is drafting paperwork to declare the opioid epidemic a national emergency. We haven't seen that paperwork yet, but I'd like to hear from you a little bit about what you think that could do and if you think that declaration is needed.
Absolutely. Thanks, Rachel. It's great to be here this morning. I really appreciate the opportunity. You know, I think the whole conversation around a declaration of emergency is really important. We convened our state health officials. We represent state commissioners of public health across the country on a virtual town hall Friday. And just the urgency of this issue on the agenda of state health officials is unbelievable. This is a priority for every state. And in fact, 6 states have declared emergencies or some kind of public health disaster. So states are already acting. Federally, what we're seeing right now in Houston and in the Southeast with the response to a hurricane is your typical emergency declaration where you can pre-position assets, you fly in, you do the acute response, day 2, day 3 recovery, and then last environmental remediation, mold, all those things that happen from a hurricane, and that system is in place. The opioid epidemic is very different. When you think just what is the analogy to a hurricane, it's as intense, but the pace of that response is definitely slower in many ways. The urgency is there, but how this plays out is different. So what we're talking to our state health officials about is what would the benefit of an emergency declaration be? And what we're hearing from our membership is it brings attention in a new way to a problem that is number one in so many health officials' minds. But in terms of specific, real, programmatic response to that, there's still a lot of questions. So if the federal government declared an emergency, would that allow grant funding from one particular program area, let's say environmental health, to be used for opioids? Would it allow federal employees to be more quickly detailed or dispatched to state health departments to respond? Would it require different kinds of reporting? The surveillance data, I'm sure we'll hear about this today, the surveillance data that we have on overdose deaths, in many states, it's a patchwork of definitions and what's on a death certificate. Would that allow for more standardization? So maybe it would allow for a quicker, more intense set of responses from the federal government. But I think the other thing to really reiterate this morning is this is both a federal problem, but a very significant state problem. It's states that respond in most cases. It's the practice of medicine is regulated at the state level. And so every state's going to have to approach this in a way that makes sense for them. Federal emergency is going to help. It's going to bring visibility, but the real action's happening in the states.
Mm-hmm. And you mentioned the real action happening in the states. Dr. Stoller, do you mind talking a little bit about how to expand treatment and recovery services? I understand Maryland has been trying to do that.
Sure, Rachel. I'm really glad to be here as well. I'm very fortunate to live in a state that has been very forward in its thinking in terms of substance use disorder and the systems. My patients love cracks, and they hide in the cracks because of the stigma when they're still using. And when there's cracks in the system in terms of having components but not stitched together, they tend to fall through the cracks. So Maryland's been looking at every possible node in terms of where patients or individuals can be engaged. including, as one example, emergency rooms. So we have pilot studies going on now where we have peer recovery advocates coming into emergency rooms to do motivational interviewing and screening and referral to treatment for people who come in for overdoses. We have some pilots where people are starting to use medications like buprenorphine in the emergency rooms and then hooking them in and connecting them with ongoing care. In Maryland, we have health homes that are located in opioid treatment programs. My patients, when they come in, they're very successful. I have wonderful regards for my co-panelists, but I have the best job here. I get to see patients change their lives in meaningful ways every day. It's a very, very hopeful job, and treatment absolutely works. But what they end up dying from eventually is cigarette smoking or the complications of other chronic problems. And so we really focus a lot on trying to get them hooked in with primary care, specialty medical care, psychiatric treatment, and other sorts of problems that now they can really focus on since they've been stabilized in terms of their substance use disorder.
And Dr. Valkov, kind of off of that, what's working right now? What's not working? What are some of the challenges in trying to curb this epidemic?
Well, we have a lot of evidence that actually what are the treatment interventions that work specifically from the treatment of opioid use disorders. And we're very lucky that we have medications for opioid addiction because we don't have them for many others. There's nothing for cocaine, methamphetamine, marijuana. But we do. We have buprenorphine, methadone, and naltrexone or Vivitrol. One of the challenges, though, is first of all that there's not sufficient infrastructure, and it has been discussed before, in terms of being able to provide with treatment for those that need it. That's number one. Number two, there is a lack of quality in terms of the way that those treatments are deployed. And one of the consequences is that patients are actually falling in the cracks. Exactly, they relapse, and there's not a support system to allow them to go back into treatment and into recovery. That is, so what is it that we are doing from the perspective? We're an agency, we're a government agency, and our task is to do research. So what we are doing research on is developing models of care that take advantage of currently available infrastructure. We all have healthcare systems in order to be able to provide treatment for these individuals that are suffering from an opioid addiction and to sustain them in treatment. So for example, what Ken was mentioning, the opportunity if someone gets in an overdose, what happens throughout most of the country is that that person overdoses, and it's unbelievable, but they are released into the streets. They give them naloxone and they are released. Guess what? Of course they go back and they overdose again. Your risk is very high. So why not use the emergency department to initiate treatment? And there are studies, one from jail, showing that if you initiate the medications while in the emergency department, your outcomes are significantly better. So this is the type of science that we call implementation science. In parallel, there's another element that also we need to face. I mean, we have 3 medications, but as a science agency, the issue is how many antibiotics we have, how many antidepressants, how many antivirals. Not every patient responds to the same type of medication, and you can have someone that responds and then they relapse. So we have actually, as one of our priorities, been developing public-private partnership initiatives to engage pharmaceutical industry to develop alternative medications that will improve compliance. For example, extended release medications. And Indivior, which is the company here, is actually developing a 1-month buprenorphine that will make it much easier. Patients don't have to go to the doctor several times a week, and they will much more likely to maintain in treatment. So that's one of the opportunities that we're doing. And there had been the question before about, are there other alternatives for public-private partnerships? And indeed they are. And again, the science is there, but we need to engage private industry to bring them into products that help. And the other thing that I do want to comment too, that we need to face, is that the epidemic was born out of a good intention of treating patients with pain, but we don't have many alternatives. So that's the other aspect where it behooves us to create public-private partnerships to accelerate the development of medications that are effective for pain and much safer. So what I'm giving you is the recognition that we have a very complex problem originated by the healthcare system that now has evolved into some of the most challenging synthetic drugs we've ever seen with extraordinary high risk for overdoses. In order to address it, we need to address this initiation, but we now need to address the fact that more people are becoming addicted to heroin, more people are becoming addicted to fentanyl, and that this is driving the overdoses that we're seeing in our country.
And Gary, did you have some thoughts on sort of the challenges and what's working here?
Sure. I think the perspective that I bring, complementary to my co-panelist, is, I've been a CEO running businesses for my entire career, or most of my career. So I bring a business perspective versus a healthcare perspective. And now that I've been really actively involved in this in the last several years since my son passed away, if I could just draw a distinction between what I completely agree here, I heard two things. I heard a lot about what should be done, and we all agree on that. And I also heard lack of implementation. And in any business, it's two things. It's the strategy, what are you going to do? And then getting it done. The hard part in business is always the strategy. What are we going to do? Implementation, usually execution, in well-running businesses just happens. It's the easier of the two. As I've come into this field, it's flipped. Everyone knows what to do. You can have panelists here for a week, and everyone will say the exact same thing. We know what to do for treatment. We're not doing it. It's not getting implemented. We know how to save lives through naloxone. It's not, there's gaps with cracks in the system. But everyone knows where the cracks are. We're not implementing it and getting it done. We know what to do for prevention. We know doctors are overprescribing. The CDC guideline came out a year and a half ago, and doctors are still not following it a year and a half later. In the business world, it would be the guideline came out, here's the system, here's how we're going to track it, here are the goals, and everyone's accountable. We're going to track it on a monthly basis. So I guess the only thing I can add, really, in summary, is I met such wonderful people over the last 4 years as I've been doing this. Very smart, dedicated people, and everyone is saying the same things, every report. We know what to do, but the implementation science is where all the cracks are.
You know, I would definitely add on that. I think that getting back to your original question about the emergency declaration, what you're finding in terms of execution is really a symptom of a fragmented system where you've got care delivery on one side, you've got the public population approach to prevention on another side, and the real need to bring this all together. And that's sort of what I think the intent of the emergency declaration would be, to say, who's in charge of this? Who's monitoring? Who's accountable? And for us at the state level right now, that's a lot of governors.
Right.
It's a lot of secretaries of health. It's parent groups holding elected officials accountable. But the sort of the national leadership for that is what I think the intent of the commission's suggestion or recommendation to declare a national emergency would be, which is to say, what are our national metrics? How are we executing? What is our strategy? And I don't think we're there yet in terms of a big national strategy.
And you know, as Gary was discussing this, and it sort of says, well, you have a business where you actually say, this is what we need to do, and here you've done the analysis, you've done the evaluation, and you put the resources to do it. And one of the aspects that we have as a challenge, and I get approached by physicians that said, yes, we agree with you that all of these alternatives for management of chronic pain other than opioids are the recommended guidelines. We don't question it. But the problem is that they're not going to be reimbursed. So if we give this treatment to the patient, there's no reimbursement. And if there's no reimbursement, there's not a path forward. And so in addition to understanding what models work and how to implement them in the healthcare system, we have to recognize that there needs to be structural changes that will include how we reimburse for services. And that's why I brought up the issue of quality, how important it is to have a way to make physicians accountable and healthcare systems accountable for outcomes on the patients. And that is fundamental. And another one that is also low-hanging fruit, but we need to be aggressive about it, is training of physicians and people on the healthcare system, how to properly screen and treat pain and prescribe opioids, and how to properly screen and treat or refer to treatment for people that are addicted to drugs. As a medical student, you are not trained on addiction. You don't know how to recognize it. So if your patient is becoming addicted, it passes you by. You don't know even what to do. So that element of the importance of training and education is a fundamental one, and it's one of probably the easiest ones that we can
Let me
do.
give you
Jerry,
a
did you
simple
wanna say-
fix to that. Now let's
Yeah.
talk about what Dr. Volkro just said, and here's a way to execute it, how I would from the business world. We know we know doctors should be taking coursework in addiction in medical school as a required course. Everyone pretty much agrees that should happen. We also, that's fact one. We know, we just heard it, and it's consistent. Everyone would agree with that. Number two, we know that less than 10% of the medical schools in this country have a required course in addiction for medical students. We know, that's fact two. Fact three, we know the Office of National Drug Control Policy, all the agencies of the government are trying to get more medical schools to adopt required course. Fact three. Fact four, our government gives out billions of dollars of low interest rate loans to students who are going to medical schools. With one signature by the president, he could say that those loans are conditioned upon the student attending a school with a required course in substance use disorders and addiction, or a course approved by HHS. The courses already exist. They're already in at 7 or 8% of medical schools. Within months of that happening, every medical school in the country would have they just pick up the required course that already exists. Within months. And that would, months, piece of cake, wouldn't cost one nickel.
Is there anything needed? You guys brought up some problems here. Is there anything that you guys need Congress to do? Any policies? Comprehensive Addiction Recovery Act passed last year, bipartisan basis. Well, what else do you guys need? Dr. Stoller?
So I think one very simple solution would be based on the fact that we know that our addicted population is aging. And we also know that methadone specifically is probably the most studied medication in all of medicine, not just in addiction, but all of medicine. We know it's extremely effective, yet there's no reimbursement for Medicare services within opioid treatment programs. I was very pleased to see that there was something related to that in the Christie Commission recommendations, and I hope that that's followed through. The other thing that I think is I really took, Gary, your comments about a business, and if there were elements of a business that were failing because of philosophy or stigma, those elements would be cut out right away. And we have problems with stigma related to addiction and the treatments that they're provided. So my patients who are receiving medications such as methadone or buprenorphine, I can't get them into housing programs, residential programs because of philosophies, even though we know that these are highly effective medications that decrease substance use, that decrease criminal behavior, and so forth. So I think we need to address stigma as well in a very direct way.
And Gary, you've said in the past that your son had felt stigmatized during his time, even in recovery. So do you mind addressing where we are as a country in destigmatizing addiction and where we need to go?
Sure. First of all, I couldn't agree more with exactly what Ken said and this question and this topic. We as a country are better than we were 5 years ago, but we're not even close to where we need to be. If you stopped 100 cars on the street out there and asked them to donate to a charity related to addiction, 10 years ago, it would be, are you kidding me? A bunch of addicts, throw them in jail. Now it might be, I get it, but they're not trying hard enough. Maybe not throw them in jail, but they're not trying hard enough. Why do I have to donate money to them? And so we're not there. But it's solvable. Again, from a business perspective, this one would cost money, unlike some of the other things that I could recommend. But there needs to be a public education campaign with message testing to really understand how you change the public's view. But the reality is, if Madison Avenue can sell kids on an Abercrombie shirt one year and the next year something else, Madison Avenue can figure this out.
Yeah.
And we can change the public's view to educate the public.
I-
We've done it with HIV/AIDS, we've done it with other things, we can do it.
I think you're right on, Gary. I think that the even this morning, the words we use are really important to remember. We use words like clean or dirty.
Right.
We use words like toxic, detoxic. We
Right.
use words like addict as opposed
Absolutely.
to someone who's in recovery.
Correct.
And that shapes our response, and it shapes how people feel about themselves and how they participate in treatment and all those kinds of things. There's a lot that the government could do. I think what's really important is realizing we're not going to treat our way out of this. We're not going to arrest our way out of this. We're going to prevent our way out of this. And that gets back to some earlier questions of the congressman. I think we need to bring to scale those things we know that work, whether it's treatment, whether it's prevention. We shouldn't have this chasm between either it goes to treatment or it goes to prevention. It should go to both. And we should be able to scale those up at the local and state level so that we're really adequately supporting our public health system to respond, the healthcare delivery to respond, and the research community to respond. Because I think there's a lot of room for new exploration there.
And I wanted to make a point. I think that in the whole notion of stigma, of how challenging it has been to change the perspective of a person that's addicted as someone that chooses to be addicted, as opposed to someone in whom, for whatever reason, the brain has changed in ways that allow them interfere with his or her capacity to exert self-regulation, to control their emotions and desires. And as we understand the problem better, as we have that insight, and with that insight comes actually solutions and treatment interventions, that's what changed the perspective. So it's like basically in the past, cancer was stigmatized. We didn't really understand it. And as we gain knowledge about what was going on, that changes. And I think that is the knowledge right now on the brain and what happens to the brain when you become addicted to a drug has advanced so much that in a way that it's making us understand why a person's behavior changes so dramatically. And what is also becoming clear is that these changes in the brain are very long-lasting, and they persist months after you stop taking the drug, which again highlights the concept that addiction is a disease of the brain with very specific changes in specific brain circuits, but they are long-lasting. It's a chronic disease. And this pertains to the whole notion of treatment and what works. When we're discussing the issue of treatment, there is this expectation that you go to a treatment program for 1 or 3 months and you're cured. You're not cured. You're actually at the early stages of your way to recovery. It requires sustained care, like diabetes, hypertension, many cancers. And that's what we need to demand from insurance, that they provide that support that requires for the management of a chronic disease process.
I think this blends the stigma question as well as the policy question, which is why don't we have full parity yet? Why is that not being implemented appropriately in the states? And what are some of the Medicaid barriers, for example, that could be changed? Some of the 90-day limits, some of the way that substance misuse and addiction services are limited, lead to the outcomes that we see versus really being supportive of folks in recovery. So some of the limits in days of service or the availability of certain kinds of services really do, I think, hamper people's recovery.
And we're going to go to audience Q&A in just about 2 minutes, so be thinking about any questions you might want to ask. And Gary, do you want to weigh in?
I just want to go back to the stigma thing. It's interesting. We've launched, one of the ways that we believe we can end the stigma is to have 5Ks around the country, walk or run, where thousands of people come together. We just had our first one in Kansas City a few months ago. We were thrilled. We had 2,400 people attend. We expected 1,000. But I know from the committee on the ground there in Kansas City, there were another couple thousand that were aware of it that said, I can't go. I don't want to be associated with this cause. I don't want anybody to figure out that my son or daughter's in recovery or that I'm in recovery. So there were so many people that just were afraid, stigmatized to be associated with the cause. And that's what we need to break through. And the fact that we had 2,400 was great. Maybe next year it'll be 4,000. And we're doing it in a bunch of other cities across the country. And when people come out together as a group, the way they did with HIV/AIDS and other causes, it'll change the stigma.
I think one of the things that will help us shift there is once people understand that it's possible to live a full and productive life with an addiction, that people I see this every day, people going back to work, people engaging again with their families, rebuilding their lives. I spoke just this past week to my patients about these hurricanes that came through, and we talked about how in the midst of the hurricane, you're sort of huddling and protecting yourself, and once it's out, you see what devastation is there, but that it's an opportunity to rebuild. And I see this all the time, and people surpass me in salary, and they are very happy in their lives, and they have families, and they're able to meet their responsibilities again. And I think that once people realize that that's the case, then there won't be as much of a sense of not wanting to admit to themselves that they have an addictive disorder or that their family member does.
Absolutely.
And thank you very much. We're going to take it over to some audience questions here. So anyone have a question, feel free to raise your hand.
Hi, my name is Tanya Chaudhary, pharmacy student from the FDA here. I have a question about the role of interprofessionalism in this epidemic. We see here and heard throughout this session today that physicians play a big role. We've heard from Congressman Tonko earlier that the access to nurse practitioners and physician assistants has now increased. Coming from a pharmacy perspective, one of the things that we have noticed in research is that the access to Narcan or naloxone is something that is not properly educated to the general public. So my question today was, do you guys see a role of public education to interprofessionalism in this epidemic, or are there already efforts in place? Thank you.
I think there's two partners that are left out of the conversation pretty often. One are the pharmacists, the dispensers, if you will, and I think in terms of public-private partnership, there's lots of opportunity there. Certainly, public education around Narcan or naloxone standing orders in a lot of the states is critical. I think the other profession that's left out of this is the dental profession, and we talk a lot about prescribing guidelines for physicians, but it's the anecdotes I hear about folks getting, wisdom third molar extractions and getting 90 days worth of opioid to treat pain, where I think we've got a lot of room to go in terms of engaging dental schools as well as medical schools. I think the notion that there's going to be one approach to this that's going to work across the country, we really need to really disavow ourselves of that. These, like I said, the medical profession and the health professions are regulated at the state level. Every state has a board of medicine, every state has a nursing board, every state has a pharmacy board, and how they implement guidelines and what they require of their providers is very different. And politically how they operate is very different. And beginning to engage the states in conversations about what the challenges of interprofessional partnership are is really, I think, quite important. The comment earlier about raising the cap on buprenorphine prescribing and including nurse practitioners and physician's assistants in some states is a hot button where they're fighting scope of practice between physicians and non-physician providers. And so the ability to do that is going to be stymied in that debate. And so there's a context in which all of this is happening that I think is really state specific, and it makes our nation great because we do things in many different ways and we can innovate, but it also holds us back sometimes because there's not going to be one central way that this works.
Mm-hmm. Yeah, and I want just to say that too, that what the opioid epidemic has actually faced us as America is actually some of the challenges exactly that are derived from the fact that rural communities are very affected by the overdoses, and we don't typically have the infrastructure that allows us to treat in very difficult to reach populations. So again, the need to develop new models of care that can allow to reach out to them. And there was the question if there was public-private partnership to take advantage, for example, for telemedicine type companies that would allow this possible. And I think that that is an opportunity that we need to expand and to incentivize those companies to work with government to actually develop new products that will allow us to have a much permeate the areas that need this type of treatment.
Mm-hmm. Mm-hmm. Dr. Soler, did you want to weigh in?
Sure. So I run a hospital-based program. We have many different disciplines within a short distance, so it's sort of easy for me. However, what I've done is reach out to area medical providers, psychiatric providers, and try to engage them. We've also reached out to the medical school, and in fact, I bring 30 patients to the medical school each year to be interviewed by the medical students, and it's a transformative experience for them and really impacts the stigma that they might come into these meetings with. I think that we need to expose other professionals to this from very early on, from the professional schools, nursing schools, psychology programs, social work schools, medical schools. And what I found is that there's a huge receptivity to that, and that once they start working with this population in settings that aren't only crisis-oriented, like emergency rooms, then they catch the bug just like I do and really love working with this population and are part of the solution.
And thank you so much, everybody. We're out of time, but thanks for the great discussion.
Thank you.